Welcome to Psych Talk. I'm your host, Dr. Jessica Rabin, a licensed clinical psychologist. If you are a mental health professional, student in the social science field, or just interested in psychology and mental health, this podcast is for you. Although topics discussed on this podcast are similar to therapy, Psych Talk is not a replacement for therapy and is for educational and entertainment purposes only. So let's dive into today's episode. Hey everyone, welcome back to Psych Talk, and thank you so much for joining me for today's episode. Today I have a very special guest with me, Kaytlyn Gilner, who is a Master of Social Work grad student and soon-to-be therapist, as well as the host of the Not So Dumb Blonde podcast. Kaytlyn, thank you so much for being here today.
Hi, Jessica. I'm so happy to be here today. It's so good to finally catch up with you again.
Yes, I am so excited to catch up with you again. If people are unaware, I was on Kaytlyn's podcast, so go check out her podcast and especially our episode. But for those of my listeners that don't know you, can you introduce yourself, a little bit about your background and what you do?
Yeah, totally. So as Jessica mentioned, so my name is Kaytlyn. I'm an MSW student and soon to be therapist, but I'm also a case manager. And then I host the Not So Dumb Blonde podcast. And I'm also just a mental health educator and advocate. But honestly, the reason why I do this work is just because I read it, not because I read about it in a textbook, but because I've actually lived it. I have lived experience and it's something that I'm super, super passionate about. And just to give a little bit of context, where this came from and why I became so passionate about it, why I started doing what I do is because when I was a teenager, I was diagnosed, or they tried to diagnose me at the age of 12 years old, which is super, super young. And you know this, working with teens with borderline personality disorder. And
I knew that's where that was going. And I could feel myself when you said 12. I was like,
I was like 12 or 13. It was right around the time that I had started my period and, going through all the hormones. But for years, honestly, because of that, I just truly believed that there was something fundamentally wrong with me, and it shaped so many parts of my life, unfortunately. And with that, I really began learning more about trauma, attachment theory, and how the nervous system adapts to chronic stress. And everything started to click, right? So I realized that so many people are walking around asking, like, what is wrong with me? And it's just a common thing that I hear a lot. And I'm sure you hear it a lot as well. And honestly, the reason why I came about this and became so passionate about this, because the more important question that people should honestly be asking is, what happened to me? Not what's wrong with me, what happened to me for me to adapt and learn these coping mechanisms, right? So as I got older, doctors began telling me, you don't have BPD, like you have CPTSD, right? And so for the first time, it helped validate my emotions, my experiences that I had growing up. And that was the first time I felt like, okay, wait, I actually have a chance. Like, I feel validated. That's why it really just became my mission to make sure that psychology was understandable and reduce shame, and just honestly help people understand that many of the things that they're criticizing themselves with are just coping mechanisms to survive and things that they've experienced. So that's just a little bit about my background. I know I said a lot, but I just think it's so important to talk about the why behind it.
No, thank you so much for sharing that. And, today we're going to be talking about trauma, CPTSD, BPD. And, one of the questions I was going to ask you is like how you became so passionate about it. And obviously you just shared that. So thank you so much for sharing your own journey. And I guess to build upon that, like, I know you are currently in graduate school, you're working towards being a therapist. Like, are you specializing in working with these types of clients as well? What has your clinical experience looked like?
So my specialty really is in trauma, attachment science, and dialectical behavioral therapy. I'm very passionate about all three of those things. And honestly, just helping people navigate trauma in their relationships, because honestly, that is the most difficult part, right? When you have trauma, it's not just navigating what you're feeling internally, but if you're already dealing with these internal parts of yourself that maybe you feel ashamed of, that you're struggling with, that doesn't go away when you get into a relationship, and we all crave and desire connection. So those are the things that I specialize in. And honestly, I think it's just because it's some of the most misunderstood areas in mental health.
Yeah, absolutely. So, to really kick off our discussion, you mentioned CPTSD. So, for people unfamiliar, complex post-traumatic stress disorder. So, can you define for listeners what CPTSD is, maybe some common signs and symptoms of it? Because I think people know what PTSD is, but
Yeah.
maybe might not be as familiar with CPTSD.
Totally, totally. And it's a really good question. It's important. And earlier before this interview, I was thinking, what is a good like visual to explain it? Because
Mm,
I'm super visual. And when I think of things and like that and I can visualize it, it helps me really understand. But I like to think of PTSD as, if you have like a bowl or a jar, and hopefully this is not like, if it's dumb, tell me. But if you have a bowl or a jar, right? Because I just thought about this before and I was like, that makes sense to me. We'll see. And you have different color M&Ms, right?
mhm,
And essentially like you're layering the M&Ms and then you have, say they're red M&Ms, and then you have an episode of a traumatic incident that you're experiencing. So then you can put a layer of green M&Ms, right? Well, that's PTSD. That's a traumatic experience that occurred. Then you can put in the red M&Ms back in and it starts to fill up. And when you look at it, there's one event that happened down at the bottom where you can see where there's these green M&Ms. So
mhm,
it's clear where you can see where it began and where it ended. It doesn't mean that there's not some residual green M&Ms kind of floating through the top, but you can slowly start to see it weeding out where this person is eventually able to look back and say, okay, this is exactly what I need to work on. And this is where some of this pain and these coping mechanisms are coming from. But someone who has complex PTSD, which unfortunately is really just more chronic, it's
mhm,
multiple episodes of PTSD throughout a person's life. So then you say, okay, we have that jar, we have that cup of M&Ms. It's clear, you can see through it. You have some red M&Ms at the bottom, and then you get thrown in some green, some red, some green, some red, and all the different color M&Ms all the way up to the top. And when you look at that, you're like, where do I begin? I don't know where the trauma
mhm,
started. I don't know where it's ending, and it's very overwhelming because it's chronic and it's just kind of scattered throughout a person's life. So to me, that really is just kind of the difference. It's having one or two incidents that a person can explain very point blank, this is what
mhm.
happened, versus basically my whole life, has been
Yeah.
like this.
Yeah. The visual made sense to me.
Good.
So
I
I
just came
liked
up
it.
with it. I was like, wait.
No, but I mean, I think, for visual learners,
Yeah.
that just gave them something to visualize. And for non-visual learners, you still explained like one of the big differences, or the biggest difference, is like the singular or one or two events that the trauma is directly related to versus the repeated
Yeah.
chronic nature of
Yes.
CPTSD.
Yes. And one thing I didn't do though was talk about some of the signs and symptoms,
Mhm,
just because I think it's really important. So, CPTSD, like I said, it's developed after prolonged or repeated interpersonal trauma. So that can just be like neglect. That can be
mhm,
just having inconsistent caregiving growing up as a child, emotional abuse, domestic violence, growing up in an unpredictable environment, right? Where your nervous system is just like constantly trying to adapt. And so some of the symptoms of that can really include emotional flashbacks. Another
mhm,
big one is chronic shame, like shame for feeling how you feel and not really being sure how to explain why you feel how you feel. Difficulty trusting others, and also difficulty trusting themselves is another big one.
mhm.
People pleasing, hypervigilance, emotional dysregulation, unstable sense of self worth, and then relationship difficulties is going to be another big one.
Yeah. And I'm sure we'll get to this later in the conversation when we're talking about BPD, or borderline
Yeah.
personality disorder. But like, as someone that doesn't specialize in this, like hearing a lot of that, I hear obviously there's the clear trauma symptoms like the hypervigilance, the flashbacks that we see with PTSD, but
Mhm.
then you got into like what you said at the end about the relationship difficulties and things like that that we think of more with like borderline
Mhm.
personality disorder, but also what you highlighted earlier when you talked about like your passions and your areas of expertise is that attachment and that relational component. Because, I mean, you know this probably better than I do. Like, trauma does significantly impact the way we relate to
Mhm.
ourselves, others, and the world around us. And, I work with so many clients that have trauma, and they talk about how, they can't keep friendships or can't keep a relationship, or they don't understand why they're so reactive to certain things. And when we dig deeper, it stems from trauma, whether that's a singular trauma or, like you said, multiple traumas over time.
Yeah. And I think you really hit the nail on the head there. I think what makes it so difficult is not fully understanding because to the person who has experienced the trauma, it does feel very real, whatever it is they're feeling.
Mhm.
And it is real. It's real and it's valid what they're feeling. The difference is just learning how to express how they're feeling, right? And another thing that I love to talk about too is that research shows that people who have trauma are more likely to perceive neutral facial expressions as negative. So,
Mhm.
just that in and of itself creates a lot of conflict. If a person who has trauma hears that, it's helpful, right? Because they get to understand a little bit about, what's going on with themselves, but then it can also flip and turn into this self-gaslighting and being like, okay, well, actually, how do I know if what I'm experiencing and what I'm feeling is just my trauma? Am I perceiving this correctly or accurately? Or is
Mhm.
it real because it feels real to me? And so that's a lot of what I really focus on in my practice as well. And two, another thing is I created this free guide called Anxiety versus Red Flag, just to help people really understand because it's just so common within individuals who have trauma to just not fully know what's their gut feeling and what is past
Mhm.
trauma. And it just kind of perpetuates just having that back and forth. And again, that can contribute to being more reactive. And because of the amount of pressure and shame that individuals who've experienced trauma feel with having these emotions.
Mhm. I love that you highlighted about it's not, you didn't use the word neutral, but like
Mhm.
neutral
Yeah,
faces, because I have seen that, I have heard that, but whether it's faces or just like neutral or ambiguous situations,
absolutely.
my clients that have experienced trauma interpret it through a trauma lens or
Mhm.
hypervigilance. And so they're going to interpret these very like neutral or ambiguous situations as a threat or as negative or whatever word we want to use. And that goes back to how trauma impacts how we navigate the world around us. And if we're always interpreting anything that could possibly be perceived as something other than positive as overwhelming, fear, um, negative. I don't love the word negative, but you know what I'm saying. Like,
Yeah.
that's going to be a really hard thing. And then, like you said, then they're questioning themselves, like, is this actually something I should fear? Is this my trauma? But it feels real. So maybe it is. And yeah,
Yeah.
it's a cycle.
100%. And that's why I just think it's so important to have the tools on hand. That's why I talk so much about dialectical behavioral therapy, because that honestly changed my life. Because how an individual is feeling, it is real to them, and therefore it is real, right?
Yeah.
But there is a difference between facts and like this is objectively what's happening and feelings, right?
Yeah.
And feelings are not always real. So not they're real to the person, but it doesn't mean that they're always accurate, right? And
Hmm.
so they're not facts. And so having those tools on hand for individuals who feel like they may be experiencing this in DBT, we have a bunch of different tools that can be used. FAST is another good one, or checking the facts is another
Hmm.
good one as well. And it really helps you be able to look at it and be like, okay, wait, this is how I'm feeling. This is what actually happened. And you can
Yeah.
visually look at it. And again, how the person is feeling is correct. But when you see that, it may actually help an individual look at the situation differently enough to handle it in other ways that
Hmm.
foster a healthy relationship and a healthy connection, right?
Hmm. Oh, absolutely. One thing I love doing with my clients, whether it's related to trauma or like anxiety or any type of interpersonal difficulty, is like asking like what actually happened or what was actually said versus how did I interpret
Mm-hmm.
the situation? Because we're all going to interpret things through our own lens. But then if you break down the actual event and it's like, oh, that person's face was pretty flat and they said okay. Those are the
Mm-hmm.
facts. How I
Yep.
interpret it as they're so upset with me. They think I'm a horrible person, like whatever it is. And then you can, exactly like you said, you can lay out. And then if you're able to identify these things, start using the tools that you learn through therapy, or even sometimes I find like being able just to label something as like,
Mm,
okay, that was a trauma response, or that was an anxiety thought, or
yeah.
that was me being hyper vigilant, like having the language to label it, even if you don't in that moment change anything, can be helpful.
Oh, totally. And I always like to ask people to think about a time when somebody thought like very strongly that they were doing
Hmm.
something or saying something that that's not what they meant, right? Because
Hmm.
that can help kind of put it into perspective. And for me, many years ago when I was, healing through this, that is what actually helped me. It took me to be in a relationship with someone who was like, "No, that's how you're feeling." And I was like, oh my gosh, that's how I've made other people feel. And I
Hmm.
understand that he's not right about how I'm feeling, but he like
Yes.
really believes it, right?
Yeah.
And so it kind of helped put into perspective that, maybe the things that I'm thinking and feeling, they're very real to me, but it doesn't mean it's an absolute truth
Truth.
of what's happening. Yeah.
Yeah. No, I thank you so much for sharing that and sharing your insights. And I'm sure as we continue to
Yeah.
chat about this, more skills will come out. But I know you shared your journey of
Yeah.
not getting an accurate diagnosis. And I
Hmm.
also know that we've just been talking about like so many things that are challenging for people who have experienced trauma.
Yeah.
Another challenge is that CPTSD is not currently recognized in the DSM. And so I
Hmm.
wanted to like talk to you about how do you think that impacts clients getting an accurate diagnosis as well as the clinical care they receive? Because you're talking about all these
Yeah.
great interventions, but if clinicians aren't diagnosing because it's not in our diagnostic and statistical
Hmm.
manual, like I don't know, what are your thoughts? What have you seen?
Yeah. So, I mean, this question really gets to the heart of like how we understand mental health, right? So,
Hmm.
diagnoses are not just determining treatment, but they're shaping how people understand themselves and others, right? And that's why this is so important. CPTSD is recognized in the ICD-11, which is the International Diagnostic Criteria, right? But it's not a standalone diagnosis in the DSM-5, which is what we use to diagnose here in the United States. So that in and of itself is a little bit confusing, right? But
Hmm.
there are different treatment methods for different things. And as you know, as a clinician, in order to get things covered by insurance, there has to be a diagnosis, right?
Yeah.
Which is an unfortunate part about our society and how things work culturally here. But there has to be something. And so when CPTSD, it overlaps with so many other different types of diagnoses, right? ADHD, depression, anxiety disorders, and borderline personality disorder.
Mm-hmm.
And so I want to just be super clear because borderline personality disorder is absolutely a legitimate diagnosis. I'm not knocking that at all. And many people genuinely do meet the criteria for it. And that's just the
Hmm.
truth. But at the same time, there is ongoing conversation among trauma researchers about whether or not some individuals diagnosed with BPD may honestly just have unrecognized complex PTSD or both conditions altogether. So when somebody comes in who might have trauma, right? And then they immediately get diagnosed with borderline personality disorder. You're telling this person that their way of being and how they've been their entire life is disordered.
Yep.
Like, how does that not affect a person? And again, I'm not saying it's not a legitimate diagnosis, but that is why it's so important to accurately diagnose to the best of our ability
Yep.
to ensure that individuals are one, getting the treatment that they need and reducing stigma and shame. And I don't want to talk, I know I'm already talking a lot, but I do want to say something also that makes me more passionate about this too is history. So
Hmm.
for centuries, women experiencing emotional distress or chronic pain or anxiety, or even just like postpartum depression or symptoms or the effects of abuse, okay, were diagnosed with hysteria. And this is
Hmm.
what the research shows. A lot of women were being sexually abused by their family members, they were being sexually abused by people in the community, or they had children and then they were struggling with anxiety and they were immediately diagnosed with hysteria and or sent to an institution that was more like punishment, right?
Yep.
So that's our history. So a lot of researchers and clinicians nowadays are saying that BPD is more just like modern day hysteria, potentially, right?
Hmm.
So again, if we're drawing those parallels, it's just important to ensure that people are getting the right diagnosis to reduce stigma and shame and to ensure that they're getting the right treatment because the treatment for BPD might be very different than for CPTSD or even just like ADHD or
Yep.
an individual might have both.
Hmm.
So I think that that's why it's really important.
Yeah. I loved that history lesson. Thank you for that. But yeah, no, it is hard. And like you said, we are both based in the US. Not
Yeah.
all my listeners are, but it is unfortunate that if a clinician takes insurance, we have to bill a diagnosis to get it covered, basically.
Mhm.
And so, yeah, if our DSM, if our country doesn't recognize, or the way that we diagnose doesn't recognize CPTSD, and it's somebody coming in using their insurance, they're still going to have to get a diagnosis.
Totally.
Um, and, we'll get into BPD here in a minute, but I would imagine, even just like hearing your story, that can also be invalidating in some ways because it's like, okay, I've been labeled with this, and like maybe that's right. I don't want to like
Mhm.
question this person that is an expert in this, but it also maybe doesn't feel
Mm.
right or doesn't feel like the whole picture or something is missing.
Yeah.
And you and I both know, unfortunately, BPD carries a lot of stigma.
Yeah.
So not only self-stigma, but like stigma from
Yeah.
other people.
Yeah. And I'll mention one other thing too. And I just want to tell, and I think it's an important story, but another reason why it's so important to have CPTSD recognized in the DSM. When I was a kid and I heard my mom talking to the doctor about this, I heard the doctor say, you know, they had discussed the BPD diagnosis and they said, you know what, to my mom, we can't do that because it'll ruin her life. Nobody will ever work with her. She won't ever get help. I mean, she's going to be basically shunned. As a 12 or 13-year-old hearing that, oh my gosh, like, do you know,
Yeah.
every day I walked around thinking like I couldn't trust any of my own actions or behaviors because I was like, this is, you know, not okay. And then another important thing is that I really, it is when I was diagnosed with CPTSD, as opposed to thinking my whole life that I may or may not have BPD, because I was never officially diagnosed with it, right? But
Okay.
there were discussions about it when I was a kid. I I finally, for the first time in my life, being diagnosed with CPTSD, felt validated and
Hmm.
felt finally I wasn't ashamed of who I was. And I know that that's not everybody's experience, right? A diagnosis is helpful for some, and
Hmm.
and sometimes it's not. And sometimes a BPD diagnosis is very helpful for some. But for me, getting the CPTSD diagnosis allowed me to finally accept that I had gone through a lot and give
Yeah.
myself the grace and validate myself of like, you've been through some shit. And it's time to finally recognize that instead of being mad at yourself for not being like everyone else, right? And
Hmm.
where that really began was I was watching a documentary on Jodi Arias. Do you know who she is?
Hmm.
Okay. I was younger. I don't remember when this was. Um, and she had murdered her boyfriend, right? This
Yep.
is like an extreme scenario, but they kept talking about how she had borderline personality disorder. And because I had heard that when I was a child and I was
Hmm.
watching this representation of what BPD was, I let people treat me horribly in
Hmm.
relationships because I didn't feel like I deserved any better. I
Yeah.
truly didn't, because I was like, well, that's what I am, you know, even though I wasn't, I'd never
Yeah.
done anything violent but you know what I mean? Like that, I was like, this is how society views me.
Yeah.
So again, having that diagnosis and realizing, okay, well, one, the stigma of BPD is changing a lot. It is not only probable to go into full remission. It's not
Hmm.
only possible to go into full remission. It is absolutely probable.
Yeah.
So that is another reason why I love talking about this, is that it is one of the most treatable personality disorders that exists, and it is proven by research. So that is hopeful. That's another reason why I like to talk about it. But also just remembering that, you know, there are treatment methods, and whether even if you have BPD, it's okay because there's nothing
Hmm.
wrong with you.
Yeah.
And I just think that that's just another really important thing to note and talk about when we talk about diagnosing, is that you don't have to accept any sort of diagnosis. And if it helps you, then it helps you. Good. Let's get the right treatment. If it doesn't, then let's talk about something else.
Hmm. Yeah. One thought that keeps coming up, and then I want us to actually talk about borderline
Yeah.
personality disorder because I know you and I know, but just to make sure we're all on the
I
same
know.
page
I
with the
already keep
listeners.
jumping the
No,
gun.
no, no, no. No, it's a great conversation. But as you were talking and like hearing your story, but also just like thinking about what you said about like borderline personality disorder is one of the, if not the most treatable personality disorders. I remember when I was in grad school, and I mean, I've been out for a little bit, but it's not like I went to grad school in like the
Mm,
1980s. Like it's
yeah.
like I haven't been out for even a decade yet.
Yeah.
But I remember like learning like, oh, you don't diagnose personality disorder till 18 because, a
Hmm.
personality is fixed and da 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 da. And obviously the research coming out is showing like, especially with BPD, like you absolutely can recover and go in remission. But even the words like personality disorder versus like complex post-traumatic stress disorder,
Hmm.
one innately in the name is whether intentionally or unintentionally, it's coming across as putting the blame on the person
Hmm.
versus putting the blame on the circumstances.
Hmm. Their
And I think,
experience. Yeah.
and that in it of itself is going to make people feel a certain way. Like like you said, like instead of saying, what's wrong with me, what happened to me, if you have a complex post-traumatic stress disorder, there was a trauma, there was a stressor. If you have a borderline personality disorder diagnosis, it's focusing on you because like we're taught from kids from early
Hmm.
on, like, oh, you have like a fun personality, outgoing personality, type A person, but like personality is usually associated with things that
Hmm.
are like innate traits to you that
Yeah.
don't
You were
change.
fundamentally born with it, you know? Yeah.
Yeah.
It's very different.
Yeah. So that was my thought. But so since we've been talking about BPD,
Yeah.
for listeners that may not be as familiar with borderline personality disorder, can you talk a little bit about what it is? And we've already kind of touched on the stigma, but maybe any
Yeah.
other stigma, misconceptions, things
Yeah.
of that nature.
So some big stigma misconceptions is that when people hear borderline personality disorder, they often immediately think manipulation, attention seeking, or impossible to love, right? Like I said, Jodi Arias, something like
Yeah.
far, far out there, right? And while some people, of course, can have BPD and have some of those same traits of what we see on TV, majority of the individuals are not showing their
Yeah.
BPD in those ways, right? Sometimes it's just internal towards themselves. So at BPD's core, it involves intense emotional sensitivity. So, difficulty regulating emotions. So, when I think about BPD, I think about an emotion regulation disorder, right? So,
Mhm.
someone who just really struggles to regulate their emotions. So, an important thing to know is that everyone experiences some level of BPD traits, and just same with narcissism, right? The difference is that individuals with BPD, they feel everything extreme. When they're very sad, they're very sad. When they're very mad, they're very mad. When they're very happy, they're very happy. And when they're very loving, they're very loving. It's also tied in with this identity disturbance as well and unstable relationships.
Mhm.
Oftentimes, individuals with BPD also struggle with a history of hospitalizations and or self-harm or suicidal ideation.
Mhm.
So to me, that is how I picture BPD. Now, when we talked before about CPTSD versus BPD, what clinicians are saying and what I'm hearing, I think we're all just trying to figure it out. Again, there's no absolute truth. I talk about this
Yeah.
a lot. It's like dialectics. Just because I say, this is what, it doesn't mean anything. But how clinicians are beginning to perceive it is that individuals with CPTSD have more of an avoidance of feeling the pain and emotions altogether, as to where individuals with BPD, they like, again, they have all these overlapping fears
Mhm.
and traits, but individuals with BPD might have more of that intermittent anxious and avoidant back and forth, but individuals with CPTSD may just feel an overall sense of just avoiding emotions altogether and kind of keeping the door more closed, if that makes
Mhm.
sense.
Yeah. No, and that's really interesting for me to hear because, like I said, this is not an area that
Yeah.
I'm an expert in, but what I have read and heard, similar to what you've already touched on, like it with more research coming out, because isn't we joked about this before we hit record and I was about to throw out a statistic. So you can tell me, I'm going to do it, but you can tell me if I'm wrong or be like, I don't know.
I love
But I
this.
remember reading like years ago, like it's something like over 90% of individuals that have BPD have a trauma history or something. Like or
Yeah.
like trauma and
Yes.
BPD are highly associated.
Yes.
Like,
And so, no, you crushed it. It's actually, it is changing a little bit now. I think it's like 75 to 80%, but
okay,
it's still a very high
high.
percentage. Very
Okay.
high. Yes.
And so with that, like I think from what I've read and learned from other people like yourself who are much more knowledgeable about this topic is, like you said earlier, some people may have one, the other, or both, but if all these people who have been diagnosed with borderline personality disorder have this significant trauma history, and we're getting a better understanding of this idea or this diagnosis of complex
Hmm.
PTSD, how many of those people have really had CPTSD the whole
Right.
time, and we just weren't considering the trauma piece?
Probably a lot.
Yeah.
Yeah. Probably a lot. And so I think that that's why now this is such a big topic that people are talking about on the internet. And some people are saying altogether to get rid of the BPD diagnosis to get
Mm,
all together. Again, I'm hesitant to say anything either way because
yeah.
I'm just a person. Even though I study this, it doesn't mean I know, what's best.
Mhm.
But I do just think it's very, very important to acknowledge the experiences, right? Instead of just being like, okay, and as a social worker, we're trained to look at the person in their environment. We're trained to look at systems. So, putting a BPD diagnosis on someone without fully assessing, first of all, the environment that they're in currently, but
Mhm.
also the environment that they've been in throughout their entire life, I think it's it's not doing justice, and
Mhm.
I just don't think that it's fair.
Yeah. Oh, I would absolutely agree.
Yeah.
Um, and I know you also just highlighted so one of the key differences, what's coming out in the research is that people with CPTSD tend to do the avoidance
Hmm.
of the emotions. Are there other key differences that you have seen or read in your
Yeah.
research? Because they do have a lot of overlapping symptoms.
Yeah. My short answer is no. In my
Okay.
opinion, I think that there's just, it is so similar. Again, how I perceive it and
Mhm.
the way that I view it is that, BPD, if you have an official borderline personality disorder diagnosis, it may just be more disturbing to the individual's life. But
Okay.
again, I don't even know if that's even true. I mean, I've really spent a lot of time looking into this. And I mean, I've heard people say that it's more of the avoidance piece, but I don't even know for sure if I think that that's true. It
Yeah.
is really just, I think people are just trying to figure it out and make sense of things. We all feel much more comfortable when we have black and white answers. And I
Yeah.
just don't think that there is one here.
Yeah. Well, I mean, if we're talking about trauma in general, there's nothing black
Yeah.
and white about trauma other than
Yeah.
I was going to say, other than I would say most people would agree certain things are traumatic, but even that's not
Yeah.
true.
Oh yeah, 100%. And one other thing too, I want to make sure I don't forget, a massive misconception of individuals with BPD is that they are manipulative or purposely trying to manipulate people. The truth is that individuals with BPD can be manipulative, but that is not their intention. Their intention is to
Mhm.
to stay safe and avoid abandonment. As to where individuals with narcissism, right? And the only reason why I bring this up is because a lot of people say that BPD and narcissism are the same thing, and like it just is this whole thing, right? Individuals with BPD are not, their intentions are different. It can
Mhm.
look the same, but this is where intent really does matter, especially when we're talking about diagnosing an
Yeah.
individual. You have to look at the intent and where is it coming from? Are they coming across manipulative because they're trying to avoid being abandoned? Are they coming across manipulative because they're actively trying to gain power and control? Are they coming across manipulative because they're just, you have to look at that.
Yeah. Oh, absolutely. I mean, I think understanding the intent or purpose behind a behavior, or even what the behavior is doing for the individual. Like, I work with a lot of eating disorders, and one of the
Mhm.
questions I always ask my clients whether it's the first assessment or early on, is like, what is your eating disorder doing for you? Because
Hmm.
you wouldn't be engaging in eating disorder behaviors if it wasn't serving you in some way. Now,
It's
that way
serving a
doesn't have to
purpose.
be adaptive, but
Yeah.
it is and like you were just talking about the manipulation. I hate that word, but
Yeah.
yeah, like it's going to serve a purpose. Like, is it coming across as manipulation because this is the only way the person knows how to not be abandoned or not feel like they're being abandoned? Is
Hmm.
it to gain power? Whatever it is, but all behavior serves a purpose. I mean, if we go back to basic like childhood development,
Yes.
behavior 101, like kids throwing tantrums or things
Children
like
are manipulative AF. Babies are manipulative. My dog is super manipulative.
like but it's serving a purpose because it's
Yes.
getting attention or a need
Hmm.
met in some way. And we've not explicitly said this, but like it's coming through the conversation. Like when people have
Yeah.
experienced trauma, the way that they get their needs met or view things may look different
Hmm.
than people who have not experienced trauma because they have learned to adapt and cope in whatever way they
Yes.
have given their trauma.
Yes. And it doesn't mean that they're actively trying to hurt you or get
Mhm.
over on you, which is how often times people perceive it.
Yeah, absolutely. So you just brought up narcissism. We've been talking a lot about like people confuse narcissism with
Yeah.
BPD, with CPTSD. You mentioned
Yeah.
ADHD. Like when we're thinking of, because another theme throughout has been misdiagnosis. Like when
Hmm.
thinking about misdiagnosis, when it comes to people who have experienced complex trauma, are there other misdiagnoses
Yes.
that that
You
you
got
have
it.
seen, or even like um I don't know, like I don't want to say like underdiagnosing things,
Yeah,
like ignoring certain symptoms. Like what have you
totally.
seen?
So I do not know the number right now, so I'm not going to throw out
Okay.
the statistic, but I think it's above 50% of
Okay.
individuals with BPD have a co-occurring diagnosis of something else. So
Okay.
bipolar disorder is a big one. ADHD also, because
Mhm.
ADHD also has more impulsive behaviors, emotion
Yeah.
dysregulation problems as well. And so I think that it's just really important that when we look at this, and if an individual listening is like, oh my gosh, ding, 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 like something, you can have, there are so many different overlapping symptoms and you can have all of them. And guess
Yeah.
what? It's okay as long as you're
Mhm.
treating the symptoms and you know what it is that you're feeling that's causing you distress, that's causing you distress in your relationships. You can work on it. But
Yeah.
I would definitely say those are the most common ones, ADHD and bipolar disorder.
Yeah. No, thank you. And don't even get me started on bipolar disorder and borderline personality disorder because
Yeah,
the amount of people that also confuse those. And I'm like, their
they're not the same.
diagnostic criteria aren't even like
Yeah,
anywhere
they're different.
close. But
Hmm.
I hear that all the time. Like,
Yeah.
I'm doing an intake and I'm like, any family history? And they're like, well, my mom either has like bipolar or borderline. And I'm like,
Yep.
"Oh, very different." But I mean,
Two very different things.
it's not my story to share, but I have a
Yeah.
close friend of mine whose mom was diagnosed with bipolar disorder for many, many
Yeah.
years. And I remember being an undergrad, like doing my abnormal psych class, and I'm like,
Yeah.
doesn't sound right. Like, but I'm just like a lowly undergrad. That sounds more like borderline personality
Hmm.
disorder. And so, I bring all this up because, like you said, we're all trying to work it out, but even like you're going to get disagreement among different clinicians based on
Hmm.
their lens, their training.
Exactly.
Um, and I think one thing you're highlighting so well is like at the end of the day, like it's about the symptoms you're experiencing, how they're affecting you, what you are feeling, and making sure that you are getting help for those symptoms, regardless of what label is slapped on to those symptoms.
Exactly.
Okay. I wanted to make sure I
Yes.
wasn't like
No, a
misinterpreting
hundred
what you were saying.
percent. Yeah.
So speaking of getting help, um,
Yeah.
so you've mentioned dialectical behavioral therapy a
Yes.
couple times throughout. So I'd love for you to share any more about that you want. But like, what are some therapeutic approaches that are best suited for
Yeah.
individuals who have experienced complex trauma and or borderline personality disorder or the
Yeah.
symptoms of either?
Yeah. Totally. So one thing I always like to say when I start this out, because I used to just be such a huge proponent of DBT, and individuals were like, well, that didn't work for me. And so I
Mhm.
want to be clear that there are multiple different treatment methods, right? For some individuals, they may need to process some of their trauma first before
Mhm.
focusing on the tools and how to navigate them in real time. For other individuals, they've spent their whole lives over intellectualizing, going to therapy, trying to figure out what to do. And they're like, I know everything that's going on. I know my whole trauma history, but I still, in the moment when I'm dysregulated, I still act incorrectly, right?
Mhm.
So EMDR is going to be really, really, really good. And even CBT for helping kind of like process some of the past trauma and what has happened. And I think that that is like kind of the first step, right? Is understanding for some individuals, right? Now, Dialectical behavioral therapy, one of the reasons why I love it is because I am very visual. I like tangible facts and statistics. Dialectical behavioral therapy is one of the most well-researched treatment
Mhm.
methods for borderline personality disorder. And I like to say CPTSD just because of the overlapping traits, right? But they are, different diagnoses. So I say that lightly with a grain of salt. But neuroimaging shows also that DBT, after 1 year of completing DBT, an individual's amygdala, oh my goodness, does it shrink or expand? It gets bigger, right? So when it's smaller, that's when, okay. Either way, it changes how the amygdala acts, right? It
Okay.
changes the activity in an individual's amygdala and it changes the shape and the size of an individual's amygdala. Neuroimaging shows this. We know this. This is a fact. So being able to see that and look at imaging and say, oh my gosh, this is the brain before and after, for me, that's tangible. I like to
Yeah.
see that. And also, individuals who have borderline personality disorder, they, after 1 year, no longer, I think it's like 65% of individuals no longer even meet the criteria for BPD after that. So that is like extremely promising for individuals who
Absolutely.
think that they're helpless and that they're broken. Having that there and to be like, no, look. And so
Mhm.
that's why I love dialectical behavioral therapy because, again, there's so many moments where we're like, okay, I know what's going on, but I still don't act how I want to act in the moment. That's where DBT comes in. That's what DBT does.
Yeah. No, thank you for sharing all of that. And I love numbers and statistics
Yes.
and things like that. And I love how you also highlighted like for some people they need to process their trauma first. For other people, they need to learn the skills first. And I think that's one of the beautiful things about the mental health field is there are so many evidence-based interventions for the same thing so we can meet people where they are. And
Hmm.
because for some people, like, I mean, I've worked with so many clients that they're like, I know I have trauma. I know I need to process it, but I am not ready to go there. But I want to learn skills or I want to work on X, Y, or
Hmm.
Z. Other people are like, I don't think I can I don't have the capacity to learn these skills until I
Understand
process
myself and what's
my
happening. Exactly.
exactly. And so, and what I'm hearing you say too is like, there are multiple therapies. Like, yes, DBT, like you said, is one, if not the most well-researched treatment
Yeah.
modality for borderline personality disorder. And we know there's a number of different trauma therapies that
Hmm.
people um, can use. And so I think for listeners who, if anybody is like, oh, this sounds like me, know that you do have options. And at some point in your life, DBT might be the best thing for you. And then at another point, it might be EMDR or it
Hmm.
might be another
Exactly.
trauma-based therapy. And then you can build upon and take from each modality what works best for you.
Exactly. Exactly. You don't have to just choose one or the other. Usually people will do
Mhm.
multiple different types of healing modalities.
Absolutely. Well, Kaytlyn, like I could talk to you for hours. I have loved our conversation. I know we have touched on so much, but I also know we
Yeah.
probably have so much more
Yeah.
we can touch on. But to be mindful of your time and the listeners'
Sure.
time, as we're wrapping up, is there anything I haven't asked you about that you would like to touch on? Anything that maybe we've touched on, but you're like, oh, I didn't say this and I want to expand on it. Just like last thoughts on
Yeah.
anything.
No, I just want individuals to know that, no matter how broken you feel, you're not broken and nothing needs to be fixed. And one of the best ways I think we can empower people is to instead try to get them to change how they're feeling, which I do think unfortunately is what happens to individuals who may have grown up feeling too sensitive or too much, is helping empower them to know like, no, this is how you're feeling. Own how you're
Mhm.
feeling. It's okay. We just need to work on how we're expressing it if we want healthy relationships, right? And
Yeah.
maybe an individual might not be their priority, right? But I just want people to know that they're not broken. They're not
Yeah.
broken and you don't need to be fixed at all. There's nothing that needs to be fixed.
I love that. Thank you so much for ending on
Thank
that
you.
message. So the last question I ask all my guests is where can people connect with you and where can people listen to your podcast?
Yeah, totally. Okay, so my podcast is Not So Dumb Blonde. You can find me on anywhere where you find podcasts. And then my YouTube channel as well, where I have a mix of both my podcast episodes, the full long form videos, and then also shorter, more technical tools on how to use dialectical behavioral therapy and stuff like that, is on my YouTube channel at Therapy K. And then my Instagram is NotSoDumbBlonde_pod. And then I have another Instagram as well for my Therapy K account, which is separate from the podcast, which is just at It's Therapy K.
Awesome. And I will put
Perfect.
all of that in the show notes
Thanks.
of this episode. But thank you once again so much for coming on. Thank you for sharing your knowledge, expertise. I learned a lot from you. I'm sure the listeners have
Great.
learned a lot from you as well. And I just appreciate you taking time out of your schedule to chat with me. It's been so great chatting with you again.
Thank you. It's been a pleasure. Thanks for having me.
And thank you, the listeners, for joining for today's episode of Psych Talk. And I will catch you in the next episode. Bye. Thank you for listening to today's episode of Psych Talk. Please rate, review, and subscribe to the show. And if you enjoyed today's episode, please share it with a friend. Don't forget to follow me on all socials at Jessica Lee, PhD, and the podcast at Psych Talk Podcast on Instagram.